Hi, hi, hi. How are you? Lucky. All right. I have a hard time with this tonight. Anna Mary, Avme. Hi, on YT. How are you doing? Say I was about to take a 5 minutes break and Carousel woke me up. Carousel says hello. Little Queen, how are you doing? Michael Ladd. Yeah, I have some nursing care plan questions and answer. So we'll do those tonight. All right, let's see if we can fix this thing. I'm supposed to record. Nah. See that record? Not supposed to be recording. Okay, let me get this thing started up. But how are you guys doing? Start early and early, right? Alrighty, and then hope it's not too small. Let me send out this live now. How do I do this again? All right. And I see 4 persons on the live. If you don't mind sharing the live, that would be nice. I try to share it with a few persons that I am able to share it with. Graham, how are you on YT? I see 17 persons. How are you guys doing? Thank you for tuning in. Yes, remember to go ahead and follow the page here. Join me for the session on Tuesday. Well, we're saying Mondays and Wednesdays. That's all? Yeah, we're doing Mondays and Wednesdays now. If you can pop on Tuesdays and Thursdays, I'll do show up on Tuesdays and Thursdays just the same. But I'm switching over to Mondays and Wednesdays at 8 p.m. Central Standard Time. Yeah. And if I can come on a little bit earlier, then I will do so as well. But it's just going to work out in my favor a little bit better with the timing and everything. Okay, so never give up here. All right, let me send it to her, Carousel. Okay. I'm trying to send it as much to as much persons as possible. Okay. I think that's as much as I can send it to. All right, so yeah. Remember to tap up the live, share the live with your friends. But how's your day going so far? My day wasn't so bad, you know. Mine wasn't so bad. I came out of the house and went and visited some patients, and it was all right. It was all right. The road wasn't so bad, but the off-road was awful. I passed my exam on the first attempt. My DMs are open if you need any assistance or advice. Kayla Dominique is saying that. Congratulations. Vanessa Warren, welcome, welcome, welcome. Patricia, who is joining me on the live for the first time. Donta, Ella, welcome. Thank you so much for liking up the live. Nurse Jones, welcome again. Yes. Who is joining me for the first time on YT? Just drop a heart. I don't think Graham is joining me for the first time. I've seen your name before, Graham. Kit, welcome. I know we're a little bit early. TDS player, okay, welcome, welcome, welcome. Evans Angel. Okay, nice. Kim T, welcome. Crystal. I think Crystal is joining us for the first time. Ocean, 870. Thank you, Ocean. Thank you. Yeah. So, Anna, welcome, welcome, welcome. If you hear the little sound, it's a projector that is making that sound. It's like right underneath the phone there. Dorana, welcome. All right, so I know I'm on a little bit early. I think I have enough questions. Of course, seriously, you have a beautiful smile. Thank you, thank you. Yes, this is what I help with healing my patients with. You know, I use it to heal my patients. Sometimes they need to see a little bit of a bright smile. But sometimes that's all they need, you know. Yeah, sometimes they just need a smile. But thank you, though. AP, welcome, welcome, welcome. So tonight we're going to be doing some questions. If you're joining me for the first time, I'm Stacy. Stacy Ann, that's what is on my birth certificate. Stacy Ann. Go by the name Stacy. That's fine. And I'm on YouTube, TikTok, Facebook, Instagram as ThinkNursing. So you can find me there and follow. I do post. I try to be consistent on the platforms. I'm still learning, you know, social media. So bear with me. Bear with me. But I'm originally from Jamaica. And my first page is on YT, on YouTube. So go over there and support me. I know a lot of persons don't really switch over on the different platforms. But if you're passing through on any of them, just go ahead and subscribe. If you're wanting any other nursing contents that we do share, in terms of the live streams, they're all posted on YouTube. So in order to get them, you have to go over there and subscribe. All right. So we do talk a lot about, you know, nursing on my page, as the name suggests. Anything to do with international nursing, I talk about it. As I said, we study as well, and just about everything else. Try to just, you know, put one or two things on my page. Still working on a few things, but just bear with me. Christ is King. Peter Kilmer, welcome, welcome. So my background is in emergency room nursing, but I'm currently doing house call. I'm going to be starting, well, I started doing nursing home. I'm excited about it. I don't have that much patience as yet, but you know, eventually. But my background is in emergency room nursing. That's my baby. And yeah, I miss it some days. But like now, I don't really miss it. Because I don't see anybody saying nurses can stay home. Just like, you know, since the start of the week, my son hasn't been to school. And every day I see they're sending out message that, oh, school is closed. You know, the teachers, they get days off. They get extra days off. I'm not really missing it right now. I'm not really missing it right now. Because usually I'd have to be out and about going into the hospital at this time of the day. Well, night. Because most of the time I'll be doing night shift here in the States. So I'm not really missing it. So kudos to all the wonderful nurses that are out there that are working the night shift and doing the day shift, the paramedics as well. I see you. All right, just be safe out there. The road is really bad and we have some folks that are driving really, yeah. I don't know what's happening. And that's in Texas here. I don't know about the other states, but this morning when I was going out, some persons were driving and the speed was probably about 80, 90 and up here ice upon the road. I don't know what's up with them. But just be safe out there and that's just it. All right. And feel free to go ahead and tell me anything that you want, you know, me to talk about on my page. If you have any questions, feel free to go ahead and ask them. If you have a topic you want me to talk about, feel free to, you know, inbox me, DM me, and I will go ahead and share that. All right. And then from there. Anyways, it's 7:43. I want to say full speed ahead, right? Or we should wait until 8 o'clock. We don't want to leave out our regular folks, you know. I decided to jump on early. I'm not see Carousel yet. And Carousel is one of my, you know, my biggest follower on TikTok. So I haven't seen her pop onto my live as yet. So CC, welcome, welcome, welcome. So where are you guys joining in from? I see 16 persons on my live here. How many persons are joining in for the first time? Just drop a heart in the comment box. Who is joining me for the first time? And I see one person on YT left here. Who's joining me for the first time? Just drop a heart in the comment box below. Let me see who is new to my page. Moms in Scrubs. Okay, welcome, welcome, welcome. Nice having you. Nobody else? Patricia Williams joining in. Princess. I don't remember seeing Princess before. Welcome, welcome. Una shy. Una shy. Una shy like me? Huh? Fatty. No, Fatty. I've seen Fatty before. Do you snore when you sleep? Anthony's asking if I snore when I sleep. When we're really, really tired, Anthony. Yes, when we're really, really tired, Anthony's gonna ask, do you have any sleep videos? And want to hear snoring videos? That's the next question. Anthony always come on to my live and ask the same question. Right, Anthony? Oh, Lord. I know the folks and I know the names. I have photographic memory. I know the names and I know the questions that some persons come on to YT nowadays and ask. Unless I'm going to change up the game tonight. Sweetheart, welcome, welcome, welcome. Ronnie Banton, welcome again. Rushy Brown. Denise Martinez, welcome. You change your mind, Anthony, about your question? Yes, I'm French. It's my first time to see you. Okay, Fatty. Okay. Welcome, welcome, welcome. Stacy, welcome. Pandora. All right, so Anthony changed your mind about the question, the follow-up question. Sparks, too sweet. How are you doing? I know it's been a while, Ronnie. I know, I haven't seen you in a while. I got done with med-surg. Okay, nice. Well, tonight we're gonna be doing some what are we doing tonight? Some care plans. So that should be good for you tonight. We're gonna be doing some care plans tonight. Oh, put me on there. So, oh Lord, I forgot to say shots me out here. Yes, I am doing well, you know, Sparks. And sounding well as well, yes. I'm doing well, thank you. Okay. We're just waiting until some time run out for some of these folks. Zeus, welcome. When are you doing maternal and pediatric care? So we did a bunch of questions for maternal the other day. And we did fluid and electrolytes. We touched on a little bit of pediatrics. So you're going to have to go onto my YouTube page to get the full live streams, Ronnie. So go and look for those videos that I posted over there. So they're in a folder on my YT page. It's ThinkNursing, one word, the same as the handle here, and you'll find them. I try to label them according to the questions. Yes, try to label them accordingly. But I did posted them on my page. So they're in the folder playlist called NCLEX question. I think they say I'm supposed to optimize my playlist, but I don't really know not much about optimized playlist. Just go ahead and just put them accordingly. So it's called NCLEX live streams. Yeah, that's the best of it. NCLEX live streams for international nurses. That's what I name it. So all of them are there. And we did, as I said, we did fluid and electrolytes. And you know, we already did cardiology. There's a lot of pathophysiology questions over there. So just go through and A, B, G, EKGs, a mixture. So delegation, priority. Yeah. Oh, thanks for the gift, Sparks. So just go over there and see, look through. And if there's anything you're missing and you want me to probably get some questions and we discuss them, feel free to inbox me and I'll try to do that for one of the live sessions. I'll try to mix it into, you know, the questions that we will be doing. We did a bunch of sepsis as well. Questions. But how are you guys finding the live streams though? How are you guys finding the live streams? Let me hear what it's saying. Very informative, the live when I come on. Okay, no problem, Sparks, no problem. I know not everybody is able to come on. Sometimes, you know, like when person send me live streams, depending, I'll try my best to pop on. Sometimes I might be late, sometimes I'm sleeping. So it depends. Sometimes I see the live late. I mean, I talk about you, Sparks. Every time I see the live, sometimes I'm late, but when I do see and I pop on, then definitely. Yes, that's how mine is. User 843. No, we haven't started as yet. You're pretty early. I'm just waiting for folks like you to show up for, you know, the time. So you're pretty early. So I know I set my time for 8 o'clock. My new time is 8 o'clock Central Standard Time. So I don't want it to be a case where I jump on too early and then the folks who normally show up for the live missed out on it because I was just a little bit too proactive. You know them way there? It's going to be unfair for them. So let me just come and chit chat for a little bit, or else I'll probably around there sleeping. And then I'll wake up and my eyes are boggy. I'm in a really the mood. You know the way there? You know, sometimes you just feel like you want to sleep and then the life just feel boring. You're there and the life just feel boring as well. Yeah, so I didn't want that to happen. So when I saw someone texted me and say, hello, I was like, yeah, I guess they're waiting. DJ Million 876, hola. I don't know if you're here. Rod. It's okay whenever you can come on. Rhythms Live is always... Yes. But you know, so Spark, sometimes I don't really know Spanish like that still, you know. I don't know Spanish. So sometimes I'm over there, hear the beat, the rhythm is good, but me don't know Spanish. So that's the other thing. Oh my word, the Spanish beat me bad. But you know, I will rock for a bit and then I'll call it a day. I'll learn from it. Okay, nice. Oh, so you don't speak Spanish? I thought you did. Nurse Yams, it's been a while. We need to kind of catch up. It's been a while. Terry Will, how are you doing? Oh, you understand some stuff. Yeah, I can pick one and two, you know, I can pick up one and two things because I did Spanish and French in high school. So, yeah, I understand one and two things. So if them chat me, me know. But in terms of making full sentences, no. Mm-hmm. Yes, it's been a while, Terry. You've been missing. You've been missing on my live. How's the weather in New York? Will's Digital, how are you? I'm glad you're doing well. I'm gonna... Okay, no problem. Not a problem. Not a problem. Thank you for stopping by. All right, thank you. You too. Mr. Smith, welcome. Four Seasons, welcome. Dwayne, who else is here? Remember to share up the live, tap up the live. 5 more minutes. And this is not the Jamaican 5 minutes. See here, this is the American 5 minutes. You know when they say if you're late by 1 minute, you're late? Yeah, man. This is American 5 minutes we're talking. We're not talking about the Jamaican 5 minutes here. Okay, this is the one time the Jamaican 5 minutes is not. Jamaican time now gonna really work out. So as soon as the clock's at 8 o'clock, we're heading out. We're getting going with our live. Okay, you're at work, Nurse Ems? Because you know Jamaicans always late, right? Jamaicans always late. When them tell us 5 minutes, don't believe them. Do not believe them. When them say, oh, I'm 5 minutes away. And next year that. Next year. We don't know time. We don't know time. So. And it's not purposeful. It's not purposeful. Don't get me wrong. It's not purposeful. Alright. But Jamaicans don't really know time that well. So when I got here, it was a bit of a, you know, you're on the night shift. It was a little bit difficult for me to adjust initially. Not saying that I'm a late bug. I'm not usually tardy. But yeah, is it the beginning or the end? Hillary, almost the beginning. It's the beginning. You're early. You're early. Someone, Wagwan. Tina, welcome. Thank you for the gift. And remember, if you haven't subscribed as yet, go ahead and subscribe to my YouTube page at ThinkNursing. Follow on TikTok. Pustain, Sugarcane, welcome. Jasmine Walker, you have a piece of my name. Yes, Destiny. So we have 3 minutes remaining. Is this thing open? Okay. Alrighty. Yeah, so as I said, we're gonna do some care plans. I think tonight is the first time we're actually doing full care plans. We're doing full care plans tonight. So this should be fun. Or probably boring. I don't know. Let's see. King Street. All right. All right. Yeah, 8 o'clock now. Let's turn the camera. All right. So welcome, guys. Thank you so much for tuning in. And as usual, we'll save the patient. I'm going to want nobody rush me here. If you don't get it, remember, say some slow persons are here. We're going to say some slow persons are here. Some person will not get it yet. So let's just make them get it. And then we'll move on to the question. But I don't want to not tell me, say next. All right. Just bear with us. Just bear with the ones in the back. Okay. Thank you so much, Autumn. Mrs. Ricketts, welcome. And thank you guys for the follow. All right, let me turn the camera around now. Flip. Okay. And let me fix this. Hold on 1 minute. Uh-oh. I think we're going to have a problem tonight with J Bess, welcome. Okay, let's see if I'm gonna flip the camera here. All right. How is that in terms of, you guys are able to see it, right? Yeah. All right, let me turn off one of them lights here. Light. Tina, good. Hot mess in control, good. Okay. So as usual, we choose one answer, save the patient, and we can go through, discuss it so everybody can be on the same page. Clear up a little bit of a confusion. You teach me, me teach you, and we're good. So the first question, let me just zoom in a little bit because some persons probably not able to see so well. Okay. So a client with acute decompensated heart failure is admitted with dyspnea, crackles in all lung fields, SpO2, 88% on room air, and jugular vein distension. Which nursing diagnosis is the priority? Is it A, activity intolerance? Activity intolerance related to imbalance between oxygen supply and demand. B, impaired gas exchange related to alveolar capillary membrane changes. C, excess fluid volume related to compromised regulatory mechanism. Or D, decreased cardiac output related to altered contractility. Zipporah, welcome. So a client with acute decompensated heart failure is admitted with dyspnea, crackles in all lung fields, SpO2 88% on room air, and jugular vein distension. Which nursing diagnosis is priority? I see B, and then C. Impaired gas exchange related to alveolar capillary membrane changes. Nice. Okay, so airway and breathing comes first. Airway breathing, circulation comes first. Crackles and low oxygen saturation indicates, hold on there, it looks a little bit blurry. Hold on. Hold on 1 minute. Okay. Indicates the lungs are not exchanging gases effectively. Excess fluid volume is important, but gas exchange failure is immediately life-threatening. Decreased cardiac output is real, but the most urgent physiologic problem is oxygenation. Always think about what is going to kill the patient first. Okay? And as we say, we're looking at the priority for this patient with acute decompensated heart failure. Pustain had said C, excess fluid related to compromise regulated mechanism. So if you're looking at the signs and symptoms here of the patient, you have dyspnea, crackles in the lungs, the SpO2 on room air, and the jugular vein distension. As I say, just think of which one will kill the patient first. The fact that the patient is hypoxic, the saturation here is low, just think of that one first. So your impaired gaseous exchange will be priority. Then you can always go on to your excess fluid afterwards. All right, Pustain. Okay. A nurse is caring for a patient with acute pain related to surgical incision. Which outcome best indicates the plan of care has been effective? You have a patient with acute pain related to surgical incision. Which outcome indicates best plan of care the plan of care has been effective. A, the patient requests pain medication every 4 hours. B, the patient reports pain level decreased from 8 to 3 out of 10. The patient verbalized understanding of the pain management options. And D, the patient sleeps for 6 hours uninterrupted. B, okay. The patient reports pain level decreased from 8 to 10. So that's Tina, Kia, Ishe, T, welcome, Pustain, Sol, Sammy. C, says C. Patient verbalizes understanding of pain management options. So, and Zipporah says B. So the patient reports that the pain level has decreased from 8 out of 10 to 3. So always, when you think about your outcome, anything that is measurable and patient-centered, that is what you're looking for, okay? So the patient score change is objective and directly evaluates the diagnosis. So understanding is very, very important. They understand the effectiveness of whatever is happening there. Sleeping may happen for other reasons, but understanding in terms of the outcome, make sure you're a little bit more specific and it must be measurable. So the patient understands that their pain has decreased from 8 to 10. That is something that is telling you that there is an indication of with the effectiveness of the medication. I passed my NCLEX on first attempt. My DMs are if you need assistance. So outcomes must be measurable and patient-centered, okay? A patient with COPD is on oxygen at 2 liters per minute via nasal cannula. Which assessment finding requires the nurse to modify the care plan? You have a COPD patient on 2 liters of oxygen via nasal cannula. Which assessment finding requires that the nurse changes or modifies the care plan? A, the respiratory rate of 20. B, the oxygen saturation of 88. C, the barrel chest, shaped chest, or the productive cough with fixed sputum. So you have a patient with COPD, and the patient is on 2 liters of oxygen via nasal cannula. Which assessment finding requires the nurse to modify the care plan? So based on your assessment, you will go ahead and change something because, oh, this is not, right for the patient. Something is going on. Which option would you change? So the respiratory rate, is that normal? You can go, the respiratory rate is good. Oxygen saturation, this is a COPD patient, right? So anywhere A, 88, anywhere 88 to 92 is good for your oxygen saturation for your COPD patient. Would you modify that plan, that oxygen saturation? No, so that's fine. The barrel-shaped chest, expected. So your productive cough with fixed sputum. If you have a patient with productive cough with fixed sputum, you don't want to go ahead and try to fix that, right? Nadia, Sol, Carrie, yes. Rise says it's possible infection. So definitely, you can go ahead and look at that one. So the fixed sputum suggests ineffective airway clearance, requiring new interventions. So you can use hydration, chest physiotherapy to help with getting rid of some of that sputum there. COPD patients often live at oxygen saturations of 88 to 92%. The barrel chest is also expected for these patients. So always look at what is expected versus what is concerning and know the difference. I finished my 2 weeks of nursing school today and I'm already... CB, congratulations. Congratulations for finishing your first 2 weeks of nursing school. Welcome to the profession. Okay. So you have this patient in front of you, a COPD patient. We already have this actual diagnosis. This is an actual diagnosis. What can you give me another actual diagnosis for a COPD patient? COPD expected finding also polycythemia. Yes. Give me another diagnosis for that you can find for a COPD patient. Let's just brainstorm. So ineffective airway clearance. What other actual diagnosis you can think of for a COPD patient? I think we made mention of something similar earlier. Kia says ineffective gaseous exchange. Okay. Ineffective airway clearance related to productive cough. Good. All right. So we have impaired gaseous exchange. Can we find something else? So no more gaseous exchange. No more ineffective airway. One more. Let's brainstorm for another one. Impaired breathing pattern. Yes, Kia. Is dyspnea a nursing diagnosis or a medical diagnosis? Yeah, we don't use dyspnea, Alex. RN tick tick. But you can join us. You can join us. Activity intolerance. Good. Okay. It's a medical posting. Good. All right. So for this one, as we said, if you are going to be modifying the plan, you'll modify the plan because of the productive cough with the thick sputum here. You modify the plan and you can do hydration, chest physiotherapy, nebulization therapy, normal saline, inhalation therapy, things like those to loosen the secretion to get that sputum a little bit looser. Okay, let's go on to this question here. This one. You have a patient with type 1 diabetes who has a blood glucose of 48 milligrams per deciliter and is conscious and confused. Is this patient hypoglycemic or hyperglycemic? You have a patient with type 1 diabetes and the glucose is 48. Patient is confused and conscious. Is this patient hypoglycemic or hyper? Tina says hypo, Julian hypo, nice. Alex, welcome. Which nursing intervention should be implemented first? So which nursing intervention should be implemented first? Administer regular insulin, IV. B, recheck the blood glucose in 15 minutes. C, give 15 grams of fast-acting carbohydrate. Or D, notify the healthcare provider. Shegot Lock says B, recheck blood glucose in 15 minutes. So Hillary says C. So she got locks. Oh, sorry. So she got locks. And we have Zipporah says A. So Zipporah. So Zipporah says A. No C, but is confused A. So Zipporah says A. Administer regular insulin. Where are we taking this patient to after Zipporah? So A, definitely. Remember, this patient's glucose is what? 48. It's already low. So when you give insulin, what is going to be happening? You're going to be dropping that glucose further. So you're going to be wrapping that body. Okay? So, yes, you're going to put that patient in coma. So they're going to meet the Lord fast according to Buchik. Yes. So you don't want to give this patient any insulin. So this patient is hypoglycemic. The patient is conscious but confused, hypoglycemic. So we're not going to be administering any insulin because insulin is going to drop that lower. Recheck blood glucose. What said that? I think she got locks. Recheck the blood glucose in 15 minutes. You already check it here. You notice it's 48. You know that the patient is conscious, but the patient is also confused. Would you sit around with this patient for 15 minutes to recheck? Or would you just grab some, some sugar and say, just drink this? Or just go ahead and give that 15 grams of fast-acting carbohydrate, whether you have your orange juice, yes, you don't want to delay care. B is delaying care. So go ahead and just grab your orange juice, your milk, whatever it is you have on hand, and give it to the patient. Then you can always check back, your glucose later on. But definitely do not delay care because you're not so sure whether or not this is a true reading. The patient is symptomatic here, and that is what you're going with. So drink the juice, Shelby. And then notify the provider. So go ahead and give the carbohydrate there. Yes, CCC. First is important. So this patient is symptomatic. It's hypoglycemia. Immediate treatment is required. Insulin would worsen your hypoglycemia. Rechecking is only delaying your treatment, and the provider notification comes after stabilizing the patient. Treat the number and the patient. You don't want to be a case where you run to the doctor and be like, hey doc, patient in room 10 is hypoglycemic, and the doc is going to be like, so what did you do? And the patient is still there hypoglycemic. Go ahead and treat in the meantime with what you have on hand, and then let the provider know. Okay. So we said the patient is conscious but confused. Okay. So you'll go ahead and give your 15 grams of fast-acting carbohydrate. When will we give, glucagon or your dextrose? What are your indications of giving your glucagon and dextrose? IM glucagon and dextrose and IV dextrose. What is your indication? What would have been different for this patient? The patient is out cold, unconscious. Yes, worsening symptoms below 40 when they can't take anything orally. So the patient is unconscious. Exactly. So if the patient is unconscious, patient is symptomatic, definitely you would go ahead with your glucagon and your IV dextrose and just go ahead and give it. But once they're conscious, they're still confused, and once their airway is intact, feel free to go ahead and try them with, the oral food. Let's look at this question. A patient refuses a prescribed antihypertensive medication and states, I only use herbal remedies. What is the nurse's best initial action? A, document refusal and notify the provider. B, educate the patient on complications of hypertension. C, respect the refusal and discontinue the medication. Or D, explore the patient's belief and understanding. So you have a patient that refuses prescribed antihypertensive medication and states, I only use herbal remedies. What is the nurse's best initial action? Document the refusal and notify the provider. Educate the patient on the complications of hypertension. Respect the refusal and discontinue or explore the patient's belief and understanding. So I say D, 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 B, B, A. Good. Explore. Yes, you always want to go ahead and assess. Ask the patient what is happening. Find out why they don't want to take the medications. Okay, so first step is always your assessment, not teaching or reporting. Understanding the patient's reasoning allows for collaborative care planning. So always assess before intervening. Yes, I would ask their reasoning, then educate. Exactly. D and B would be part of an intervention. Yes, so you always want to find out why is it that you don't want to take the medication. Then from there, you'll be able to proper educate them on. And then you'll go ahead with documenting. Julian, welcome. Shengi, welcome. Okay. Let's go on to number 6 here. A client with a risk for impaired skin integrity as a care plan that includes turning every 2 hours. Which finding indicates the intervention is effective? So you have a patient with a care plan that is for turning every 2 hours, but the patient has a risk for impaired skin integrity. Which finding indicates the intervention is effective? A Braden score remains unchanged. The skin is warm and dry. No areas of redness over bony prominences. Or D, the patient verbalizes the importance of repositioning. C, no areas of redness over bony prominences. The goal is for prevention of breakdown. There's no redness, so that means the intervention is working. Education and scores support care but don't prove effectiveness. So you have this patient here who is at risk for impaired skin integrity. What are some other things you can actually do in terms of the management for this patient? So apart from turning every 2 hours, what are some other things you can do to help with preventing any form of skin breakdown? Keep the skin dry. Fluids and ambulation. Rise, welcome. Place fillers on heels. No shearing or friction. Adding pillows. Massage. What about those diapers? Adequate nutrition. What about the diapers that them always spend so much time, you know? Sometimes it's so heavy. Heavy. Creams. The diapers are horrible. I know. Keeping them regularly changed, clean and dry. Yes. Because sometimes you see the diapers and the diapers are so heavy. Heavier than the patient. Keep the patient well hydrated. Yes, Pustain. Pure wick. Good. Yeah, so those are some simple things you can do for your patients there. The pure wick is just as bad because sometimes they leave it there and they don't even remember that the patient have a pure wick. Okay. Prevent the diaper to be soaked for a long time. Yes, Rise. Okay, so you have a patient that is at risk for impaired skin integrity. Regardless of the diagnosis, give me 2 actual diagnoses. Just put some actual diagnoses that could be related to impaired skin integrity. Dehydration, diabetics, malnutrition, bad hygiene, pressure injury, impaired physical mobility. Okay. Risk for impaired integrity related to and post-major surgery. Okay. So you have the Alzheimer's patient, age. Your hip fracture patients. Okay. Your obesity patient. Like older patients with thin skin. Yes, Ulio. Okay. Your bedbound patients. Your risk for impaired skin integrity related to incontinence. Yeah, all of those. Okay. The nurse is caring for 4 patients. This one is a bit hard. Which task is appropriate to delegate to your UAP? Assess for your pain level in patient 1 hour post-op. Teach a patient how to use an incentive spirometer. Obtain vital signs for a stable patient with hypertension, or evaluate effectiveness of PRN morphine. We have our C's, Pustane. Obtain vital signs for stable patient with hypertension. What we know about delegating patient, UAPs cannot teach, they can't initially assess. Okay, what we know about delegation, in terms of for your nurses, what is UAP? Your unlicensed assisted personnel. Don't delegate what you can't, what you eat, okay? So the nurses are responsible for teaching. What else the nurses are responsible for? Nurses teach, nurses assess. Educate, evaluate, discharge unstable patients, evaluate. Yes. Taking action. Yes, so all of those are things that are like the primary responsibility for your RN. So obtaining the vital signs for your stable patient with hypertension. So if it requires anything to do with your nursing judgment, don't delegate, okay? And we say anything that you eat, that's what is supposed to be for the nurse. Anything that is routine can be performed by your UAPs. Non-invasive tasks as well on your stable patients can be done by your UAPs. Everything else is for your nurse. All right, remember to go ahead and tap up the live, share the live. If you haven't subscribed as yet, go ahead and subscribe, follow, and drinking the water. Uh-oh, bottle empty. Let's get one more. Go down to round 2. Thank you for the follow, Kitty. Lulus, thank you for sharing up the live. Okay. So we have this patient here who is admitted with sepsis. How do you know when you have a patient that is in sepsis? What are the criteria for sepsis? What's the criteria for sepsis? How do you know when a patient is in sepsis? How do you know when it's how do you know when a patient is in sepsis? What is the criteria for sepsis? So we have low blood pressure, confusion, high temperature, fever, high heart rate, 2 or more vitals out of range, low blood pressure, tachycardia, shock, fever, low blood pressure, white blood cell count, systolic blood pressure greater than 90. So the temperature greater than like 38. Your systolic blood pressure less than 90. Respiratory rate greater than 20. Your white blood cell count greater than 12,000. Infection, confusion, blood. Yeah, all of those are things that would be a part of sepsis. Redness, swelling, hot to touch, hypotension, tachycardia, oliguria. Yeah, all of what you're saying is a part of like signs and symptoms for Okay. Okay. So confusion. Yeah, so all out here, so guys are saying so far, okay, is greater than 22 minutes. So you have a patient admitted with sepsis, has the following findings. The blood pressure 86 over 50, heart rate is 122, respiratory rate 28, and the temperature is 102.4, and urine output is 15 mils. Which nursing diagnosis is priority? And as we say, when you talk about priority, what priority means when you hear we say, okay, what is the priority for this patient? What are we talking about? Airway, breathing, circulation. So A, definitely. Okay. Yes, what's the problem? You're addressing the problem. What is the one thing that will fix the problem? Okay. So the priority is going to be, you know the problem, what is going to fix it? So we have the vital signs here. Which nursing diagnosis is priority based on all of this here, the vital signs? Ineffective tissue perfusion related to decreased circulating volume, risk for impaired skin integrity, hyperthermia related to infection, or D, risk for infection. So we have a ton of folks saying A, ineffective tissue perfusion related to decreased circulatory volume. Why you guys say the A? Why ineffective tissue perfusion? Why ineffective tissue perfusion? Why you guys say A? BP low, if affecting circulation, okay. Hypotensive, the MAP not greater than 65. Did we see a MAP? Dino, where you see the MAP? Oxygen not reaching. Temperature is too high. So no oxygen circulating. Quick calculation in my head. How do you come about with your ineffective tissue perfusion related to decreased circulation based on your assessment here? You go in and you see this set of vital signs. You see the urine output. How did you come about with ineffective tissue perfusion? Hypovolemia, Gil 21P, welcome, welcome. I haven't seen you in a while. Yes. So what we know about sepsis, if the urine output is low, wouldn't they retain it? What we know about the blood pressure is low, that's why. Okay. So yes, what is? So the blood pressure is low, tachycardia, oliguria, looks like hypovolemic shock. Yes, so we know that this patient is in sepsis. We know that the blood pressure, everything here. This is low, tachycardic, the oliguria. So the patient is in septic shock, right? So what we know about septic shock? What's the pathophysiology behind septic shock? Fluid volume deficit. So if you have fluid volume deficit, you're gonna have decreased circulating volume. So you're not gonna have effective tissue perfusion, right? So you have ineffective tissue perfusion related to decreased circulating volume as evidenced by all of what you see here. So the patient is hypotensive. You have your low urine output. You also have the patient here being tachycardic. Dehydration, urine retention. Is this patient retaining urine? Guys, what sepsis? Come on. Streptococcus case, maybe. Use the 736. Okay. So hypertension and tachycardia plus low urine output results in what? Poor perfusion. So if you think about the pathophysiology behind it, we know about the poor perfusion. So infection is already present. So the risk. So this risk is, the risk is already, we already passed this. The patient actually has an infection. So this doesn't even apply right now. Patient can be at risk for impaired skin integrity, hyperthermia, related to the infection that is going on. The ineffective tissue perfusion is already happening because of everything that is happening here. Okay, sepsis is an extreme response of immune system caused by an existing infection. Yes, Rise. Sepsis becomes MODS. The brain and the heart want all of the blood. So Trevon is asking, what about neurogenic shock? Sepsis is serious confirmed with a confirmed infection. Yes. So what we know about neurogenic shock here? The heart. Okay, so Rise answered. So the heart rate here is what? Neurogenic shock, the heart rate is low. And it didn't really present anything. So the scenario already says sepsis. Just work with what they give you. Replying to an anaphylactic shock comment. Oh, okay, sorry. So it's a sepsis scenario. No spinal issue. The heart rate not over 200 pristine. Okay. So work with whatever scenario here that is given, and then from there. The fever matters, but circulation is failing, so go with airway, breathing, and circulation. So you have this patient here. Can you give me another actual diagnosis for this patient? Low blood pressure, no movement to move the blood from the heart. Lack of brain function from lack of breathing. Okay. Give me another actual nursing diagnosis. So we have one diagnosis here. What could have been another actual nursing diagnosis for this patient? So I have a sepsis patient here. What could have been another actual diagnosis? Nursing diagnosis. Ineffective thermoregulation. Nice, Rise. Flu is a medical diagnosis. Nursing diagnosis. I say risk for, so the patient already has the infection, so there's no risk here. No risk for any infection. This is a full-blown infection going on. Full-blown sepsis. Risk for acute confusion. Good. High risk of shock-related infection. Just add a monitor for anything, and it's a nursing diagnosis. We can't manage Dino. Hemorrhaging. No, that's not a nursing diagnosis. So based on the scenario, the sepsis scenario here, what could have been another diagnosis? Risk for acute confusion. Risk for bleeding. I'm not gonna put an X beside a risk for bleeding there. Haney. So we have, let me go down here. Risk for impaired gas exchange. Okay, we never had a O2 sat, but that could be, yes, it's a risk. Yes, it's a risk you have there. Okay. Trevon, you don't know nursing diagnosis? Risk for electrolyte imbalance. Good. Are you just thinking about all the different things? This patient is going to be, or you're a med student. Oh, so this patient is going to be, is in shock. So there is fluid volume problem. Okay. So decrease in the circulating volume. So there's going to be a lot of risk as well as actual diagnosis. So risk for fall due to orthostatic hypotension. But is it going to... Risk for renal impairment. Okay, so I get the gist. Good. So you have like a decreased tissue perfusion. We have the infection. Your acute, your decreased renal, cerebral perfusion. So your altered mental status or acute confusion related to decreased cerebral perfusion. Hypovolemia due to impaired circulatory volume. We have the risk for impaired skin integrity related to like your hypoperfusion. So things like those. Good. So monitor for sears. Risk for impaired wound healing. Yes, Sammy. Risk for impaired wound healing. Why would this patient be at risk for impaired wound healing though? Why wound healing? Just curious. Impaired urine outputs. Okay. Pustin. Yes, altered mental confusion. How would this patient be at risk for blood flow diverted to other organs? Yes. That is the main reason why, you know, so you're going to have the poor wound healing because of all of that. So when your body is in shock, just think of it. Your body is prioritizing all your major organs. So wound healing ineffective tissue perfusion. Yes, it is. You're correct, Sammy. You're correct. I'm just trying to figure out if what's your rationale behind it. Just like every other, you know, the body just prioritizing. Lack of circulation can cause it. Yes. So because you have decreased volume, so it's very, very important to resuscitate and get volume back, get that infection down, and then from there, due to nutrition deficiency, lack of protein, zinc, and yeah, good. All right, let's move on to this one. Remember, low urine output is present because your organs are starving. Let's look at this one here. The nurse is developing a care plan for a patient with ineffective airway clearance. Which outcome is most appropriate? So which outcome is most appropriate? The patient will verbalize correct coughing technique. The patient will have clear lung sounds within 24 hours. C, the patient will maintain oxygen saturation greater than 92%. D, the patient will receive nebulizer treatments as ordered. So you have a patient that is, the nurse is developing a care plan for a patient with ineffective airway clearance. Which outcome is most appropriate? Is it the one that the patient will verbalize correct coughing technique, or will have clear lungs within 24 hours, maintain oxygen saturation greater than 92%, or receive nebulizer treatments as ordered? So which outcome is most appropriate? So just make sure it fits your diagnosis here. So you have a patient that is having problems with airway clearance. Choose the one that is best suitable for this problem. Correct coughing technique, clear lung sounds within 24 hours, oxygen saturation greater than 92%, or nebulizer treatments as ordered. Address the ineffective airway clearance to stabilize oxygen saturation. So we see CCBA. So we have your maintain your oxygen saturation within your 92 hours. Always focus on your patient results, okay? Not nursing action. So clear lungs, sounds may not be realistic in 24 hours. The patient will receive treatments as ordered, but will that, getting the treatments, will that clear up? How will you know that this is actually cleared up? Is it really working? So you have to look at the results of what you're doing. So the patient will maintain oxygen saturation is the best one. The nebulizer treatment is going to help with clearing, loosening up that secretion, but this one is the one that is going to show the outcome of this nebulizer treatment here. So D is the intervention and C is the outcome. Yes. Okay. Oxygenation reflects airway clearance effectiveness. So that is the one that is the best suitable one. Pustain says B impaired. Okay. Let's look at this one here. A patient with tracheostomy suddenly becomes anxious and restless. Which action should the nurse take first? Okay. You have a patient with tracheostomy suddenly becoming anxious and restless. Which action should the nurse take first? A, notify the respiratory therapist. B, check oxygen saturation. C, suction the tracheostomy. Or D, assess tracheostomy placement. So first, trip on. What should you do first? D. Let's see. A, B, Beltine, Z, user. So remember, when you think of first, what are you doing? What is it that you can do? What is it that you can do independently without an order? Okay. And the first thing we can do is what? Assess. Always remember your nursing process. Assessment. So always do your assessment first. So always check your patient. So always assess before intervening unless there is a clear emergency. Not hearing me? Unless there's a clear emergency. Anxiety may indicate obstruction, but confirm first. Suctioning without assessment can cause harm. Intervention versus assessment. Make sure you know the difference and you know when to do which one first, okay? When you have when you have a first question, it's always start off with your assessment. When you have your priority, your intervention, okay? So when you see what's the priority, the nursing priority, you have a patient with tension pneumothorax, what's your nursing priority, not nursing priority, but what's the priority for this patient? Needle decompression. Okay. So with this question, what keyword would we look for to know if it is an emergency? So this. So in this question, with this question, so it just asks you which action should the nurse take first. So depending on the scenario, so it depends on what they're asking. It depends on what they're asking. But if the question asks you what is the priority, then you know definitely you're addressing the condition. What is the one thing that you want to do now? It's an emergency, so you need to address it. So you see the potassium high. What is that one thing you want to do now? If you realize, let's say, which action should the nurse do first? You see they're going to put the head of the bed up, down, you know, check the glucose, whatever it is. First is your you know, interventions that you can do independently without a doctor's order. Jacinth, welcome, welcome. O2 saturation below 88 can be an emergency, right? Yes, it can be an emergency. Depending on who. Because if it's 88 in a COPD patient, Trevon, checking if they can breathe. Okay. Airway breathing circulation, always priority. All right, let's move on to this question. A patient with fluid volume excess has a goal of demonstrate improved fluid balance. Which finding best shows this goal is met? A, blood pressure decreased from 160/92 to 140/88. B, the weight decreased by 1.5 kilograms in 24 hours. The patient reports less shortness of breath. And D, urine output increased to 40 mils per hour. So you have a patient with fluid volume excess, has goal of demonstrated fluid or improved fluid balance. Which finding best shows this goal is met? Let us see. I think this is more realistic. D, urine output increased to 40 mils per hour. Urine output, Merkin, Chuma. Pustine says D. Zipporah, user 3026 says B. Mo with a heart says a patient with fluid volume excess has a goal of demonstrate improved fluid balance. Which finding best shows this goal is met? Blood pressure decreased from 160 to 140s. Weight decreased by 1.5 kilograms in 24 hours. Patient reports less shortness of breath, or the urine output increased to 40. It is A, Minty. So we have our weight decreased by 1.5 kilograms in 24 hours. So daily weight is very important indicator when it comes down to your fluid status. Symptoms are subjective. Vital signs help but are not the best measure. So that's why you have to do your daily weights for your patients. Which patients do we normally see fluid volume excess in? On point, Mo. Period. Heart failure, okay. CHF. Anybody else? SIADH, CHF, renal patient, kidney patients, hypovolemic. Okay. And if we're treating, good. And if you're treating a patient with hyper, how are you? And if you're treating this patient, hypernatremia, if you're treating a patient with fluid volume excess, what kind of diuretics are you anticipating? Give me a few antidiuretics or diuretics that you can anticipate giving this patient. Class of diuretics. Furosemide. Okay. All right, give me the class of diuretics. Hydrochlorothiazide. Loop diuretics. Okay, one. So user says wasting. I don't know what user 736 is saying. Okay, so Ronnie Banton. So we have loop diuretic, K, sparing thiazide, sparing, potassium sparing. Okay. When When do we use the osmotic diuretics? When do we use osmotic diuretics? For this scenario, would you anticipate using like an osmotic diuretic for this patient? For this patient, would you anticipate using an osmotic diuretic? Would you consider using an osmotic diuretic for this patient? Okay, so Ronnie answer no. Good. At least you answer no, Ronnie. But user 7367 says yes. Why would you use it as user 736? Why would you use osmotic diuretic for this patient? Oh, no, you changed your mind? Okay, good. Osmotic diuretics, what are those? Yes, Trevon, what are those? Well, more depends, but the scenario tonight, this scenario, we don't have any indication based on this scenario here tonight. So osmotic diuretics are indicated for increased intracranial pressure due to trauma. Okay. Yeah, so for this patient, yeah, probably not. So mannitol is one, Nurse Life, good. So you can probably think about using, you know, all the other ones, but the osmotic diuretic is not gonna be for this patient. I don't remember them from the class. I remember them by MOA. MOA. Oh, mechanism of action. Okay, okay. I just pick up what you were saying. Because I was thinking, I was wondering if you were talking about the, what class is that again? Monooxidase. MOA, I don't remember. But I figure more or less it was a mechanism of action. Why is it not D? Okay, why is it not D? Who is that asking? So D is actually measurable, but which one is gonna give you the best result? So if you're supposed to choose between the weight and the urine, which one is gonna be the most accurate? Which one is gonna give you the most accurate result for your weight? Is it the urine or you weighing the patient at the same time each day? The weight is gonna be most accurate. So B is gonna be your answer. So when in doubt, just narrow it down and look for the one that is gonna give you the best result. Urine output 40 is good. Yeah, it is good. It's good. Medication working. So 1 liter of fluid is what? 1 kilogram. So this is pretty decent. Okay. Which patient is which patient is most appropriate for your LPN or your LVN assignment? The patient that is newly admitted with chest pain, the patient receiving blood transfusion, the stable patient with chronic heart failure, or the patient requiring discharge teaching. So which of the patient is most appropriate for your LPN? Okay, so Jojo says D, the patient requiring discharge teaching. It eases, yes. So Saru says D. So the patient requiring discharge teaching. So teaching is going to be for your nurse, okay? Just look at the key word here. So this patient has chronic heart failure, but the patient is stable. But you have a patient that is going home, but the patient requires what? Discharge teaching. That is going to be the responsibility for your registered nurse. So no teaching for your LPN here. Don't delegate what you eat, educate, assess, or treat. Okay. So LPNs are for stable patients with predictable outcomes. Blood, chest pain, and teaching require RN judgment. So keep those patients. Call for help. Call for backup. A nurse is caring for a patient. RN do more of a case management upon discharge. I tell you. I tell you. A nurse is caring for a patient with stroke. Which new findings requires immediate revision of the care plan? So you have a patient that has a stroke. Which new finding? The patient is lying in bed and the patient has these symptoms. Which require you to revise the care plan? Is it the blood pressure that is 150/90, the difficulty swallowing water, the right-sided weakness, or the expressive aphasia? So the patient is with you. The patient has a stroke. Which new finding requires immediate revision of the care plan? Blood pressure 150/90, difficulty swallowing water, right-sided weakness, or expressive aphasia? Tornado says, I don't know. Patient is at risk for aspiration. B, risk for aspiration. Which of these findings require immediate revision of the care plan? So B, so I see BRN girl says, and Lillian says B, Ronnie says B, the blood pressure 150/90. Update the whiteboard. The difficulty swallowing the water. So the dysphagia, aspiration risk is a problem, airway threat. So you want to go ahead and immediately revise your care plan for that one, okay? The blood pressure here is a little bit elevated, but the patient has a stroke. You can still go ahead and continue with monitoring and treating this blood pressure, okay? But this one here is a problem. The difficulty swallowing water, you want to go ahead and deal with that one first. The other findings are expected post-stroke, and so you want to go ahead and make sure they're able to swallow before you feed. Let's look at this one. You have a confused patient, a confused elderly patient who is admitted with acute delirium. What is delirium? What is delirium? What is delirium? What is delirium? Confusion, seeing things. What is delirium? Onset confusion. Temporary confusion. Okay. Acute intermittent disorientation. Who's this? Luke. Short memory loss. Okay. So it's sudden onset. So it's sudden onset, temporary loss of memory. Yes, when a patient is out of their normal. Okay. And when you have a patient that is an elderly patient, what is the most common cause? What is the most common reason why you have patients, the elderly patients, having delirium? What is the number one reason? An infection, UTI. Yeah, that is always the problem. The UTI. Fustine says STD. Well, in Florida, probably, well, you know, in Florida, what's your UTI, yeah? UTI dehydration, med side effects. Well, the number one cause is usually like an infection. So when those patients come in, don't hang around and wait for them to tell you that they want to pee. Just go ahead and take the urine, because it's either the bed is going to be soaked with urine and you never get the urine. So just go ahead and get your urine, straight catheter the patient, get the urine and get it out of the way. Because that's the one thing the doctor wants. So you have a confused elderly patient who is admitted with acute delirium. Which intervention should be included in the care plan? A, restrain the patient to prevent falls. B, keep the room lights off to promote sleep. Place frequently used items within reach. Or D, assign a different nurse each shift. Which intervention should be included in the care plan? C. Place frequently used items within reach. Jonas says A, restrain the patient to prevent falls. So safety without restraint is priority. Consistency and orientation reduces delirium. Restraints worsen confusion. So you don't want to go ahead and put the patient in the restraint. And that's the last thing you want to do, especially if a patient, in a restraint and then they fall and then probably they die on you. You don't want that. So when you can avoid restraint, that's too much paperwork. Restraining patient is always like a last resort. Keep the room lights off to promote sleep. That's another problem. The patient is already confused. You don't want that patient to get up in the night and then have a fall, more injuries, problem for you as well. So you want to make sure that the items that they frequently use is within reach. And not only for your elderly patients or your patients that are confused, for all your patients. So that way they don't, constantly be on the call bell. Yeah, man. So you just set the room away that them have everything in reach. Assign a different nurse to each shift. Is that something you want to do? Assign a different nurse each shift, especially on the med-surg floor. A is not warranted in the scenario and you have to have an order from the doc. Yeah, Camille. Assign a different nurse each shift. Is it something that they normally do on like the med-surg floor? No. You always want to have some form of consistency because I'm already confused. Can you imagine every night you go in is a different face? Oh my word. Yeah, so try to be consistent with your nurses. So C is the one that you will go with. Let's look at so in terms of with your delirium, so when you have a patient with delirium, is this reversible or not? Is delirium reversible? Yes. Okay, nice. Because once you treat the underlying problem, you find the culprit, then you solve the problem, right? Sure, if you can find the cause. Exactly. Let's go on to this one. You have a competent patient who refuses blood transfusion for religious reasons. When a patient refuses blood for religious reasons, what are some other options that you can give these patients for transfusion? When you have a patient that is refusing blood transfusion, what other products can they get to replace the blood? What other products can they get? So iron-rich food, isn't there now like a fake blood? What other products? Okay, so let's see. They get certain blood fractions, good. HB40 albumin plasma, iron tablets, injection, IV fluid, cell savers, yes. Dextran, IV cocktail. Putting alpha, good. Tina, yeah. So there are other alternatives to the blood that they can get. Anybody had said Dextran? Dextran is another one as well. Vegetables. Yeah. Okay. So you have a competent patient who refuses a blood transfusion for religious reasons. What should the nurse include in the plan of care? Administer blood in an emergency. Educate until the patient agrees. Respect refusal and explore alternatives. Notify hospital ethics committee immediately. And we say C, respect refusal and explore alternatives. And we just explored the alternatives a while ago. So autonomy must be respected when the patient is competent. Education is allowed, coercion is not. Competent adults have a right to refuse. So just make sure you document, and that's it. Document everything that is being discussed and the alternatives that were discussed. Put it on the patient chart, sign it. And then from there, providers can go and look at the other options that are available. Always respect the patient right. Yes. Good. What time? 9. Okay, I'm gonna go until 9:30. It's past my bedtime. Let's stop up the live, guys. Thank you guys for tuning in. Thank you for tuning in. And if you haven't followed us yet, go ahead and follow so you can be a part of the live streams on today, Wednesday? On Wednesdays and Mondays when I tune in. Thank you for following. Yeah. No, dear. Deep. No, I cannot show up daily. I'll try. I'll try. If I am finished with work and everything, I'll try my best, but I can't commit to that as yet. I do a lot of driving for work, and I still have to come home and chart. So it's a lot on my shoulder. Shoulder not that broad yet. My back not that broad. Not yet. But I'll try to pop on as frequently as I can. But on Mondays and Wednesdays at 8 p.m. Central Standard Time is the time that I'm coming on. So followed in an accelerator program and practicing through you for the NCLEX. Okay, no problem, Melly Monroe. Just go onto my YouTube page and make sure that you subscribe. A lot of questions are over there in the playlist that we've done so far. Pathophysiology questions, 4 hours worth of sessions that we've been having. I've just started to cut down on the time period. So go over there and look at it. ThinkNursing, it's the same as the handle on TikTok here. Okay. So my time now is 9:12. So it's 8 Central Standard Time for me that I'll be using for my live stream. So both RNs and LPNs can use my questions. So it's not only for RNs. Uh-oh, got ATT so stressed out. I'm sorry. Okay, let's see if we can run through. Yes, it's 9:12 for me now. Let's see if I can run through one more set of question. And then from there, if anything, tomorrow is Thursday night. I don't think I have that much patience tomorrow. Depending on the road, then depending on, I might be able to come on. I might come on in the evening, but yeah. It will be around the same time, probably 7:30, 8 o'clock, okay? So let's look through these questions. A patient, where are you? I am in Texas right now. I'm in Texas. A patient with acute pancreatitis reports severe epigastric pain radiating to the back, nausea, vomiting, and abdominal guarding. Which nursing diagnosis is priority? So you have a patient with acute pancreatitis who reports severe epigastric pain radiating to the back, nausea, vomiting, and abdominal guarding. Which nursing diagnosis is priority? A, imbalanced nutrition, less than body requirements. B, acute pain related to pancreatic inflammation. C, risk for infection. D, deficient fluid volume. B, I see 1A, Maisha. Why did you say imbalanced nutrition? And then I see here C and D, risk for infection, deficient. Okay, so whenever you have your scenarios, always think of your priority, always find the actual diagnosis. Actual diagnosis, always try to find an actual diagnosis for your priority. Okay, and then if you can't find one that is an actual, sorry, Anne, get from underneath the table, please. Come this side. No, sir. Your actual diagnosis from the scenario that they have there. Always start off with your actual diagnosis first. And then from there, if sometimes you might have a risk diagnosis that is priority as well. So you just have to be careful with how you look at the answers that they have. All right, so with this question, which nursing diagnosis is priority? This patient is acute pancreatitis. And we see all of these here. Looking at imbalanced nutrition, acute pain, risk for infection, deficient fluid volume. Which of these will you go with? Risk for infection. This is going to be something that is delayed. So you'll go with that one later, right? Your imbalanced nutrition, acute pain, you have deficient fluid volume. Choose between these three. So I see a lot of persons says your B. Api Mumu. Then Anita says D. So always go with the one that is your actual diagnosis. So your acute pain related to your pancreatic inflammation. And as we say, your priority is always related to your pathophysiology. Just think about the pathophysiology of whatever condition they're talking about. So we know that the pancreatitis is caused by the inflammation. You have some inflammation going on there. So they're going to be having a lot of pain. So that is going to be your priority. So acute pain related to pancreatic inflammation. So severe uncontrolled pain triggers stress response and worsen outcome. Nutrition and fluids, they matter, but pain is immediate problem. What is screaming the loudest? Risk for infection is a problem as well, but as I say, it's going to be delayed. Deficient fluid volume is going to be a problem because this patient is not going to be eating. This patient is going to be NPO. The imbalanced nutrition is also going to be a problem because the patient is NPO and has a clue already. Severe. Yes. And the severe is already there. What enzymes are you anticipating to be elevated? So you have a patient with pancreatitis. What enzymes are affected for this patient? What enzymes in terms of the labs are going to be giving problems for this patient? Are you going to be seeing in the blood work? AST, ALT. Okay. She got locked, says glucose. What is going to be happening with your glucose? Lipase, yes. What is going to be happening with your glucose level with this patient? Your amylase, yes. So hyperglycemic, trypsin. It's going to be high. Okay, she got locks. All right, so your glucose is going to be elevated. Do you think the glucose is going to be low as well? Are you concerned about hypoglycemia for this patient? Are you concerned about hypoglycemia for this patient as well? or just hyperglycemia? So you have this patient with pancreatitis. No, just hyper. So the patient is going to be hyperglycemic at first, and then it's going to be hypoglycemic. No, they're going to be hyperglycemic, but then after the damage, with all of that inflammation taking place, the patient is going to be hypoglycemic. So you're going to be checking these glucose like every hour, and you'll probably end up starting this patient on dextrose water. It will not produce insulin at first. Because what we know about the pancreas, insulin producer. Okay, what else we know about it? Secretes insulin and glucagon TIA. Okay, and what we know about glucagon? So glucagon is supposed to do what? So it releases your insulin and your glucagon. So your glucagon is supposed to raise your blood glucose. Okay, so if your pancreas is damaged and you don't have any glucose, any glucagon anymore that is being released, what is going to be happening? The patient is going to be hypoglycemic. So initially the patient is going to be like hyperglycemic, and then eventually going to be hypoglycemic. So you have to be watching these patients like a hawk. So they're going to be like hyper, then hypoglycemic later on. So you might find out that you're going to be having to hang your dextrose water with normal saline just because their glucose is like fluctuating. Okay, good. Let's look at this question here. You have a patient with ineffective breathing pattern related to anxiety that has been admitted. Jacinth, welcome. Patient with ineffective breathing pattern that is admitted for anxiety. Which goal is most appropriate? The patient will appear calm. The patient will verbalize reduced anxiety. The patient will maintain respiratory rate of 12 to 20 breaths per minute, or the patient will use relaxation techniques. So you have a patient with ineffective breathing pattern. Which goal is most appropriate? Patient will maintain a respiratory rate of 12 to 20 beats, and we see a C and D. Happy Mew Mew. Patient will use relaxation techniques. So the goals must be objective and measurable. Okay? So calm and anxiety are objective. The techniques used is an intervention, not a goal. And then let's look at this one. You have a patient with GI bleeding who becomes pale, dizzy, and hypotensive. What are they at risk for? What kind of shock are they at risk for? You have a patient with GI bleeding who becomes pale, dizzy, and hypotensive. What kind of shock is this patient at risk for? Hypovolemic shock, Bucheek or Bucheek. Good. Hypovolemic, Dinique, Qua. Yes, Tia. So this patient is at risk for hypovolemic shock. Vicky RN, welcome. Yes, so this patient is at risk for hypovolemic shock. Which nursing action? Yes, Liron. Which nursing action is priority? So you have a patient who is hypotensive, pale, and dizzy. Which nursing action is priority here? Insert a nasogastric tube, administer IV fluids, check hemoglobin level, or prepare for endoscopy. Which nursing action is priority? Let's see. BBB, administer IV fluids. BBB. So we always say what? You treat your shock before your test. So always go for your circulatory system, okay? Circulation is very, very important. So hypotension, the body is in what? Shock. So go ahead and stabilize first, and then we can always investigate later on. So go ahead with your IV fluids. What's the best IV fluids you're thinking? What kind of fluids are you thinking about? What kind of fluids are you thinking about for your patients? What's the best one we always go for? 0.9 honey, normal saline. Yes, isotonic fluids, normal saline to be exact. So always start off with your isotonic fluids. Your normal saline preferred. Okay. Always resuscitate with your isotonic fluids. Kat is asking why not lactated ringers? Why not lactated ringers? Why normal saline is more preferred? Why lactated ringers is more not preferred for resuscitation? So lactated ringer is used mostly for burns and some other conditions, but in terms of the osmolality, and some of the electrolytes as well. Yeah, some of the electrolytes that you have in the lactated ringers as well. Because like calcium, potassium. So, so they prefer to go with your 0.9, your 0.9. But just go ahead and look up both of them, because your normal saline, your lactated ringers, they're isotonic, but just look up both of them and see what's the difference between. But it's electrolytes. In the lactated ringers, you realize that there are some electrolytes there that are not present in your 0.9. Okay, let's go down to this question here. Okay, so we said GI bleeding, patient becomes, so we give IV fluids. Okay, prepare for endoscopy. Insert. What is one contraindication for inserting your nasogastric tube? What are some contraindications for inserting your nasogastric tube? You have this patient in front of you, and the patient is having a GI bleed. The doctor orders for your nasogastric tube. What is the contraindication to this? Let's see. Bowel obstruction. Okay, nasal obstruction, esophageal varices. That is one very big one. Facial fracture, good. Infection, nutrients, those are a little vague. Yeah. Upper respiratory tract infection. Jonas, me not feel your upper respiratory tract infection so well. You have to explain that one day a little bit more. Esophageal cancer, okay. Deviated nose. Your skull fracture. Yes. Oral surgery. Oh, sorry. Let me fix this. Sorry. For your bowel obstruction, I saw someone said bowel obstruction. Is bowel obstruction a contraindication too? Is bowel obstruction a contraindication to a nasogastric tube? And epilepsy, is that a contraindication too? Is bowel obstruction a contraindication to getting a nasogastric tube? No, it's a treatment. Exactly, it's a treatment. So you need your nasogastric tube for decompression for your bowel obstruction. And I see someone says epilepsy. They're on. Well, go on. Yes, we use it for decompression. Okay, so all right, nice. Okay, let's move on to question 19. You have a patient with ineffective airway clearance, and the patient is receiving chest physiotherapy. Which finding shows the intervention is effective? Oxygen saturation increased from 89 to 95%. Respiratory rate decreased from 30 to 22. The patient verbalizes understanding of therapy, or the sputum production increased. So you have a patient with ineffective airway clearance that is receiving chest physiotherapy. Which finding shows the intervention is effective? See, ADD, AB. Ineffective airway clearance. Snaggletooth says D, sputum production increase. Blessed Chances D, Moonlight Treasure D. Okay. So remember, look at the diagnosis. T says A. Chris A. Mernan says A. So improve oxygenation. So you have ineffective airway clearance. So there is something going on. So you have a buildup of sputum. Okay. So the patient, you get rid of that. The patient is getting what? Chest physiotherapy. And you're looking to see whether or not it is effective. So you loosen up the secretion. Then what is happening? You have the increased production of your sputum. So your oxygen saturation has increased to 95. So increased sputum alone doesn't equal success. So improved oxygenation is because of the airway clearance. So the patient is producing more sputum there. So we say ineffective. Ineffective airway clearance. Is this an actual or risk nursing diagnosis? Ineffective airway clearance. Is this a nursing actual diagnosis or a risk diagnosis? Is it an actual diagnosis or a risk diagnosis? And it says risk, and it says risk. BJ says actual. Lean, yes. It's an actual diagnosis. Maisha says actual. Bertha says actual. Honey's still holding on to risk. Why you say it's an actual diagnosis, Honey? Why you say it's yeah. So I wanted to know if it's a risk diagnosis or actual nursing diagnosis. You know, the risk diagnosis is what? The ones that are usually delayed risk. Something is, because of something, it's going to be happening. This one is already happening. The problem is there. So you have like risk for fall, risk for infection. Richmond says nursing. Yeah. Okay. Which task is inappropriate to delegate to your UAP? A. Measure intake and output. Assist patient with ambulation using walker. Obtain blood glucose via finger stick, or monitor patient for signs of hypoglycemia. Which task is inappropriate to delegate to your UAP? And all of you says, okay, Richmond change up the game, says B. Assist patient with ambulation using a walker. Happy, what D? Why is she assessing? Yes, so which task is inappropriate? Meaning, which task you shouldn't be giving this person. You can measure intake and output, yes. Assist patient with ambulation, yes. Obtain blood glucose via finger stick, yes. Monitor patient for signs of hypoglycemia, no. A LPN can do C. Yeah, but we're talking about the UAP here, okay? So the UAP does task, not thinking. So the monitoring for complication requires clinical judgment. So that's going to be for the nurse. Okay. I'm going to do this one last question. And then we're finished for tonight. A nurse is caring for a patient with traumatic brain injury. Which assessment finding requires immediate action? A Glasgow Coma scale of 13, unequal pupils, complaint of headache, or blood pressure of 140/88. Let's see, BBB, UV CAS says C. Nurse Kimmy says C. Laura says C. Complaint of headache. So you have a patient with traumatic brain injury. Which assessment finding requires immediate action? Let's go through them. If you have a patient with a Glasgow Coma score of 13, is this good or bad? You have a patient with a Glasgow Coma score of 13. Is this a good score? Good. Yes, honey. Good. So we tick this one off. You have a patient complaining of headache. A traumatic brain injury patient complaining of headache. Is that expected? You know, expected, right? So we're going to keep that one. Blood pressure 140/88. That's okay. Can tick it off. You have a patient with unequal pupils. You'll be there looking and you're wondering, why is this patient pupils unequal? Will you be sitting on with this patient, or you'll be running around the entire world trying to figure out where is the doctor, where is the surgeon? So which assessment finding requires immediate action? Is it the complaint of the headache or the unequal pupils? Let's see. The headache, the pain. No, some, I don't want the pupils, them a look, the pupils are the problem, right? And if you have unequal pupils, what is going on? Problem, right? So you have some herniation going on there. So unequal pupils increase intracranial pressure or herniation risk. This is a medical emergency. You don't want to see this going on for your traumatic patients here. Okay, so it's very, very important when these patients are sleeping, you open them eyes.
Open them eyelids and shine the light in them eye. Better them tell you, nurse, don't wake me at all. Yeah, man, let them tell you not to wake them. But open them eyes one at a time and shine the little pen light in there and look at their pupils. Because the last thing you want is for a patient to be herniating on you. Yeah, you don't want that to be happening. Because once you miss it, a problem. So, which other patients, apart from a traumatic brain injury, who else can you think of that can have, like, you know, unequal pupils? Is it because you can relieve a headache with pain meds? Okay, is asking, is it because you can relieve? It's not necessary. You're thinking about the severity. Which one is, like, you know, an emergency? Go ahead and read up on traumatic brain injury. And once you understand this, just think of it. Read up on traumatic brain injury, and once you understand it, you'll understand the unequal pupils. And it's not necessarily the pain, the headache that the patient is having. So it's not the pain medications that you're going to be giving the patient. Once your patient starts herniating, that's a problem. Alcoholic patients who tend to have like pupillary changes as well. Which patients tend to have pupillary changes? Persons under substance use. Your stroke patients post-fall. Yeah. So a lot of times, like when they're brain dead, that's you'll tend to see like the pinpoint pupils or the unequal pupils. So you don't want that to be happening with any of your patient. Or when it's fixed or dilated pupils. Okay. All right. So, well, this is where I'm ending tonight. So I was ending about, yeah, this is where I'm ending. I need to do my notes for today. But it was nice having you guys. It was nice having you guys today. Yeah. Unbroken, how are you doing? You're welcome, okay. Mamu, happy Mumu. You're welcome, Cindy, no prob. You're welcome, BSNR and Joanne. You're welcome, guys. This platform is very beneficial to me. The joint late, always switch to the joint. Okay, not a problem, Richmond. Just make sure you follow so you can actually pop on the next time. So I'm coming on Mondays and Wednesdays. I'll try to see if I can do like other days, but it's not concrete as yet. Can't guarantee it. But for Mondays and Wednesdays, I'll try to make it, you know, a point of duty to be on the live at 8 p.m. Central Standard Time. Oh, Lord. Yes. No problem. Just make sure you go ahead and subscribe to the YouTube page. The handle is the same on YouTube. and get the videos just in case you miss the live stream. All the live streams are posted on YouTube. So I'll be back on next week Monday, but I'll probably come on tomorrow. But if I am on, I'll post it on my live so you guys can see. Yeah, but it has been very, very busy for me because I spend a lot of time on the road. Yes, I do a lot of house call. I work on the road, so driving all day, coming home in the evening, trying to do notes and all of those things, it's a lot. And then trying to finish up to do some questions and then come here. Yeah. Tracy K, she's doing nursing overseas though. Okay, no problem. Not a problem, Tracy. She can actually come on to my page. It's not only focused on NCLEX. It's studying, basically studying nursing. So how can we pass NCLEX? How can we pass the exam? Tips, just study broad. Focus on your pathophysiology. I always tell people, if you understand pathophysiology, you can't go wrong with pathophysiology. And you need to take the time out to understand when they say first, initial, priority. Get that in your head. You have to know those. So you can understand what the question is asking. And if you're able to understand that, when you sit down in the question and look at it, that is exactly what it is. So I tell people that priority has to do with the pathophysiology. What is that one thing that you need to do for the patient? No, to not have the patient die on you. What is that one thing you need to do? No, to fix the problem. First action is what is your nursing? What is the one thing that you can do as a nurse, or the first thing you'll do as a nurse? You don't need an order to do it. Just do it. Okay? And then from there, once you're able to use that to answer the question, it's the same thing over and over. I recommend it if you're engaged to practical are the best. Nursing interventions. Yes. Just go through and then from there. And then the other thing is always think about safety. Nursing, NCLEX is all about safety. They're not expecting you to be the nurse that knows everything. They just want to know that you understand that if you're going to be giving a blood pressure medication, you need to check the blood pressure. It's all coming back to the same thing. Safety, 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 safety. Safety of the patient, safety of the nurse, safety of the patient, safety of the nurse. That's just it. The first thing is to check vital signs intervention. Know about, the nursing process, your nursing assessment, your diagnosis, things like those. Know about your Maslow hierarchy of needs, when to use it, your airway, breathing, circulation, when to use it. Because I know sometimes we have this thing, like some persons, when I say put it in the chat, why you put this answer? Some persons just put it there because, oh, this is what we were taught. No. Look at the scenario, and then from there, just make sure you're using the right option. Don't just say, oh, because you see an airway answer, you're just going to choose an airway answer because of that. Or oxygen problem, or oxygen answer, you just choose the oxygen because that's the one that is there. Make sure it is related to the question or the scenario that they have. All right. Just keep on scrolling, Chad. So that's the only thing I can say. Just try to read on the basic things and understand what NCLEX is asking about. Find the time to understand that. And then from there, look at questions and how the questions are set up and what the question is asking. Look at the answers. And once you're able to practice the questions and go through, see the answers, the rationale, make sure you're looking through the rationale as well, because that is going to help with you understanding how NCLEX is testing. Because you can be reading. If you don't understand the rationale behind certain things, you're not going to get it. Good night, no crowd. How are you doing? Okay, so just make sure you do that. All right. So it was nice having you guys. Remember to go ahead and follow and subscribe to the YouTube page. and my TikTok page at ThinkNursing one word. As I say, the official time and dates are going to be Mondays and Wednesdays at 8 p.m. Central Standard Time. I might pop back on tomorrow at 8 p.m. Fingers crossed. But you know, you might see me because tomorrow is Thursday. So you might see me if I'm finished with my patients early. If not, it's going to be on Monday for the official study time. Okay. You're welcome. You're welcome. You're welcome. All right. So until then, I will see you in the next live. All right. And stay safe now. Oh no, me eat chicken and fish. Annabelle. All right. Bye, guys. Okay. Enjoy your night. Bye.